Hey guys, thanks. I think we're going to get started. For those who I haven't met on this side of the room, my name's Sean Bear. I'm a volunteer at Pikesville. I work in the medical director's office, one of the fire surgeons, and I'm an anesthesiologist for critical care. So thanks you guys for coming today. We have a couple of things going on. Number one, we have a trauma assessment that Dr. Q is going to lead for us. There's also, you share your training. There's also a practical next door that we're going to do also. And then can you share, Ali, what you're doing?
Hey, good evening, everyone. My name is Ali Alamin, and I'm a postdoc fellow at the University of Maryland. I'm also a volunteer medic at Station 37. And what we're doing is, at the back, you see those mannequins that are not related to the trauma training. What we're doing is we're comparing the three devices that you have. And basically, we're trying to introduce a new device. So if you look at the other end, there's a CPAP face mask that we're using. You can't actually see it from that corner. But there's a CPAP face mask that we're using, and we're trying to advertise this speed. It's easy to use as opposed to the standard DDM. And we're basically seeing how well we can do it. So if you would like to participate, by all means, all you're doing is backing for 3 minutes each device and filling a one-page survey, and that'll be $20. I'm not taking this out of my pocket, the university's paying it, so just for your time.
What other training do you come to and get paid?
How well you did, because I've done this before, and some people were all over the place, and some are doing a great job. So if you want your own personal feedback after you're done, we can give you that. If we get a big group, I can show you how a big group in general is. But if you get only a couple people, I'm not going to share that because you can just take a look. If you have any questions, Ali?
Thanks, Ali. Great. So today's talk speaker is Dr. Farheen Qurashi.
Yes.
Excellent. Also goes by Dr. Q. I just met Dr. Q today, so I'm exceedingly happy about this. So Dr. Q is an acute care surgeon at Sinai Hospital, practicing trauma surgery, critical care, emergency general surgery. She completed her surgical training in Kansas City, Missouri, and then specialized in critical care at MedStar Washington Hospital Center. She's interested in healthcare access and disparities in underserved and marginalized populations, as well as injury and violence prevention. She serves on the Injury Control and Violence Prevention Committee for the Eastern Association of Surgery and Trauma. She's going to discuss the keys to safe, comprehensive, and efficient trauma assessments, how they relate to patient evaluation upon arrival at the trauma center, understand how to optimally communicate with trauma hospital providers to ensure effective and expedient transfers of care, also how the practical trauma assessment station plus trauma consults tonight to perform the consult on the radio using a talk-around group after completing the trauma assessment. And then we'll have some opportunity for feedback too. So, Dr. Q, thank you so much for being so generous with your time.
Of course.
Thanks for sharing.
Yes, thank you so much for having me. Hi, everyone. As I mentioned, I'm Dr. Qurashi, or Dr. Q. I work at Sinai Hospital, Baltimore. I don't know if you all are familiar, but Northwest is nearby here, which is a sister hospital of Sinai as well. Sinai is a level 2 trauma center, so you're certainly probably familiar with there's a lot of trauma centers in Baltimore. There's Hopkins has a level 2 as well. Johns Hopkins, the main campus itself is a level 1, and University of Maryland is a level 1 trauma center as well. And we'll talk a little bit about the difference between level 1 and level 2 and specialized centers a little bit later on too. But this is going to be kind of an overview, and then we'll have a chance for questions and just talking about, I know that everybody has different levels of experience, so consider this an interactive discussion about things that you're interested in or find interesting as far as evaluating trauma patients on the scene, and then when you arrive and we see you at the hospital, communicating about those trauma patients so that we can get them taken care of quickly. And then just for reference, as I mentioned, Sinai is a level 2 facility. All of the facilities that I trained at were level 1s. In Missouri, they were state designated, and then, as well as in Maryland. And then American College of Surgeons designated level 1 trauma center at Washington Hospital Center in DC. I have nothing to disclose in this talk. So objectives, as we just talked about, essentially, basically we're going to be doing partially assessments, just kind of overviewing that, as well as having a chance to practice and actually do what you just took a look at, and talking about how you communicate with the trauma team, the trauma surgeon, the nurses, etc., in the ER. So performing the assessments, something that you guys are probably even more familiar with than I am, because there's a different level of this, obviously, when I'm in the hospital or in the But number one, always, always, always be safe and take care of yourself. Just like we say to our residents and trainees when they're taking care of a patient and it's very exciting and there's a lot of blood and everybody is running around and yelling, make sure that you have your personal protective equipment on. Make sure that there's not still an active shooter or it's whatever else, or that you're going to be injured, because you don't want to just add another casualty on to what's already going on. That doesn't help anyone, certainly not you. The other thing is to be systematic, and that's the way I'll kind of go over the trauma assessments. It's the way that we pretty much do everything in trauma. It's one of the things that attracted me to trauma, is that everybody in the room knows what's going to happen first, what's going to happen last, what's the priority, who's in charge, and what we're doing. So that things, even though there seems to be a chaos, it's a controlled chaos, so that ultimately we're doing the most important thing for the patient and getting to what we need to get to when we need to get to it. This is not a full trauma life support course, as you guys are probably familiar. There is trauma surgeons, we do take a full trauma life support course that teaches us also, what we would do in the operating room, et cetera. But this is kind of what you would do for pre-hospital care before they arrive in the trauma bay, and we initiate that full trauma life support. And the other thing to remember, especially if for those of you that I hear are a little bit newer at this, again, similar to being in the hospital in any type of code situation or any type of kind of high stress situation. Sometimes you want to do things very quickly, because we're going to talk a little bit about timing and getting things done in an expedited manner, but that doesn't mean to cut corners or rush or not use your personal protective equipment, because it's always faster to just do it correctly the first time and be smooth about it and do things correctly, so that you don't have to go back and worry about an iatrogenic injury later on, or a second person getting injured later on. So has anybody, you guys have probably heard this, scoop and run, stay and play. Anybody heard that? Yeah. So these are two different schools of thought. Essentially, scoop and run means exactly what it sounds like. You're taking the patient as quickly as possible to definitive care, whether that be a trauma center or the nearest hospital if you're in a very rural facility or a very rural area, etc. And stay and play literally means you're staying, whether that is at the roadside, and you're probably doing more procedures, spending a little bit more time there, trying to further stabilize the patient than you would if you were just grabbing them and they were still somewhat unstable and you're just rushing them, coding them to the nearest facility. I will say that in the United States, based on the way that our trauma systems are developed, we tend to favor more scoop and run, just because we do have the number of hospitals separated, especially in a metropolitan area like Baltimore, that you don't necessarily need to do excessive amounts or procedures, et cetera, invasive things at the roadside or at the scene before you get to definitive care, where they can further do those procedures. But there are some places, like in Europe or Australia, that favor more quote-unquote stay and play. There are some areas of Australia that you can't get to a facility for 6 hours, so you don't have a chance to just scoop and run, because that patient will not make it to that facility. So you need to do more at the scene than you would normally here. Similar also to Europe, there are reports of people doing, I don't know if you guys have you guys heard of Reboa? Reboa is something that you can do. It's basically a catheter that you can insert into the aorta, which in the United States is sort of catching on more. They do it at shock trauma. We don't do it at the level 2 centers yet. But this is basically something that's entered into the artery and then placed into the aorta. They do this at the roadside in Europe before they get to the hospital. That's not something we have the capability of doing here. Like I said, some level 2s here, our level 2 doesn't even do that, although shock trauma does do it. But either way, so 2 different ways of doing it, and then here in this metropolitan area, we're going to focus more on getting the patient as quickly as possible out of the scene to a definitive facility, whatever that may be. The golden hour is a phrase used a lot in the trauma world. Essentially, that's the initial 60 minutes that a patient has that may determine their prognosis or their outcomes in the immediate acute hospital period. It depends on the mechanism, it depends on the patient. It's not a hard 60 minutes when evidence has gone back and looked at it. But the ideas around it are similar. Basically what you're doing to this patient, how stabilized you're getting them, how resuscitated you're getting them, and whether they're getting their definitive treatment, bleeding control, etc. Within that first couple of hours will determine how they do and whether or not they survive. Also going along with that are the platinum 10 minutes, which is essentially getting them stabilized on the scene and transported over to definitive care within that first 10 minutes after injury, so that we can use the rest of that golden hour to make sure that they get to the operating room, etc., whatever they need to do. So we'll kind of go system by system, ABCs a little bit. One thing that I did want to go over just as a background, when you're doing your assessments and evaluating a patient, transporting a patient, keep in mind, especially in blunt trauma situations like a car accident or a pedestrian hit by a car, these are patients who are at high risk for having a potential spinal injury, CT or L-spine. There are specific categories of when you would specifically put this on, which we'll go over in a slide in just a second. But this is not for the patient who has an isolated gunshot wound to the leg or something like that. Don't worry about finding a Ccollar, putting a Ccollar on that patient. Or even if they have a gunshot wound, somewhere in their thorax, an abdominal gunshot wound, etc. That's not what we're referring to, but more blunt trauma. You want to put a Ccollar on those patients. If the patient has a high-risk mechanism, pedestrian versus motor vehicle is a high-risk mechanism, high-speed car accident, etc. If it's a ground-level fall, not necessarily, but if they're elderly, they do have a high risk, actually, of having a C-spine injury, even from just a ground-level fall or a sitting-level fall. And if they do have a high-risk mechanism in addition to a distracting injury, neurodeficit, etc., which again I'll show you just a that would need a Ccollar in place. The backboard is more of an extrication and transport tool. We typically advise that the backboard be removed as soon as possible. We usually, at my trauma center, when the patient arrives and we turn the patient, that's when we get the backboard off. You can still keep the patient in spinal precautions and decrease spinal mobilization even without a backboard necessarily in place if you do need TNL spine precautions based on their mechanism. So this is what I was just mentioning. So if they do have a high-risk mechanism, as just mentioned, in addition to one of these following things, that's when you want to put a Ccollar on this patient. So if they can't move their legs, or if they complain of neck pain, or even if they don't, but they have an obvious deformity in their leg and they're just screaming about pain in their leg, they may not notice if they have a smaller fracture in their neck, in which case just go ahead and put a Ccollar on them. I'd say if in doubt, go ahead and put a Ccollar on them. Now, if the patient is extricated from the vehicle and non-ambulatory, then they will also require a backboard or spinal precautions for the rest of their spine as well. If they're ambulatory, and they do meet one of these, then it's okay to have a Ccollar on them, but they're ambulatory and then they can lay down. You don't have to put a backboard on that patient who's ambulatory at the scene. This is specifically for pediatric patients, which is less than 15 when it comes to trauma. So if they have any other kind of significant injury, or obviously if they're a child and you simply can't evaluate, if they're just crying, you can't tell, then they would meet criteria to have a Ccollar in place as well. And this, as I mentioned, if they're unable to ambulate, etc., then they would need a backboard also. One thing to note here, if they do have a neurodeficit, such as GCS less than 15, which could mean even just somebody who can move their arms and legs and isn't necessarily complaining of neck pain or tingling or numbness, but they're just confused, they would still meet criteria as well for spinal immobilization. You're going to keep in mind to, as you're doing your assessment, keep the spine protected, right? You don't want to cause any further harm. And then you're going to evaluate the patient from essentially ABCDEs. That's the easiest way to do it, and there's multiple different ways and places in medicine where that's applicable. So it's the easiest thing to stick to as well. This is what we use in the trauma bay when we're doing advanced trauma life support. So the first thing you're going to do is the patient protecting their airway. The easiest thing to do to evaluate that is just say, hey, what's your name? What happened? If they tell you, they're protecting their airway. And then you can move on. If they're not, if they're bubbling, if there's blood coming out, if they're obtunded and they're not speaking to you or not waking up, then they're not protecting their airway, and they will need some form of definitive airway. That doesn't necessarily mean that you initially that you have to immediately intubate them in the field. You can bag mask somebody for a long time. If you have a good seal, no problem. We can get them to an anesthesiologist who can get them intubated. But if you do have the equipment and you're able to get that done quickly, then that's great too. Just know that you have other tools in your toolkit as well. Also, if somebody has a neck injury and at first they're talking to you, they can lose their airway quickly, and it may not, if you get them to definitive care quickly enough, that's great, but just know in the back of your mind that if somebody is hoarse or if they have an expanding hematoma in their neck, that person may very well lose their airway that they initially had. So they're at risk of developing that if they didn't initially have it when you evaluated them. But other airway adjuncts when you're bag masking a patient, putting in an oral pharyngeal airway, especially, obesity is a big problem in the United States right now. If they have a big, thick neck, if they have a large face or any kind of swelling from an injury, having an oral airway or a nasopharyngeal airway can help you even just bag mask more effectively and get a better seal. Or an LMA if you have that available also. The big thing I think when you're bag masking is sometimes you may need 2 people to do it. Just make sure that you have a good seal, because you can bag mask and not actually ventilate very well if you don't have a great seal on that. The last option, if you absolutely need it, is to do a surgical airway, which is essentially a hole in the cricothyroid membrane. So what you do is you palpate the neck, you find the cartilage or the Adam's apple, and you go underneath. There's a little soft spot, and that's your cricoid cartilage, or your cricothyroid membrane just above your cricoid cartilage. That is within the top of your trachea. It's basically the most superficial area that you can get to. When we do a surgical tracheostomy, it's a little bit lower, there's a lot more tissue. So this is the area that we go to that you can get to quickly, with the least amount of cutting, with the least amount of blood, although I will say there's typically a fair amount of blood loss too, just because of what else is going on with the patient. But if absolutely necessary and you simply cannot get an airway any other way, you can essentially make a little longitudinal incision, take the back end of that knife, flip it over, put it in, turn it, and put a tube in. And that'll get you an airway. Okay, so now you have your airway. Say the patient is talking to you, their airway is secure. Okay, what's next? So again, just go A, B, C, D, E's. That's the easiest way to remember, going systematically, so that you don't forget anything or lose anything. So their airway's patent. Next is going to be breathing. And this is very simple. You simply, if you're able to, listen to them. If not, just look at their chest. See if there's a penetrating chest injury, if there's any obvious bleeding, if they have a flail chest, which is essentially where their chest is moving the wrong way. When you breathe in and your chest goes out, their chest would go in because they have essentially fractures that are making that part of their chest wall not communicate with the rest of it. So when there's negative pressure and they're breathing in, that part of the chest wall comes in. That can cause respiratory failure simply due to the pain and the inability to adequately inhale and ventilate. Penetrating wounds, if they have a penetrating sucking chest wound, they will need an occlusive dressing on that, preferably in the field. Once they get into a hospital, we can put in a chest tube to help with that. But in the field, if you can put on a dressing, except only occluded on 3 sides, that will help prevent that sucking of that chest wound and prevent worsening of the pneumothorax or conversion into a tension pneumothorax. So essentially, as these graphics are showing you, when the patient breathes in, it prevents air from getting into the wound or sucking in as it was. And then when the patient's breathing out, it allows them to exhale. The other thing that you may have to do at times in the field for various different reasons, if you can tell that a patient has a tension pneumothorax, it's going to be hard, even in the trauma bay, I'm sure at the scene, to tell whether a patient has jugular venous distension necessarily, sometimes even to hear breath sounds, whether or not they're really there, whether they're equal to the other side. But if you're suspecting a tension pneumothorax, if the patient is significantly hypotensive, then they may need decompression of their bilateral chest. And essentially what you do is take a large bore needle, like a 12 or 14 gauge. There's two places that you can place it. Traditionally, it was the midclavicular line in the middle of the chest here, down to the second intercostal space. That's a little bit deeper, and so a lot of times we're seeing that the catheters can dislodge into the subcutaneous tissue. Where we put chest tubes is where it's more favored nowadays because there's less subcutaneous tissue there, which is actually the anterior axillary line, so a little bit more lateral at the fourth intercostal space. So kind of right along at the nipple line, and you're able to get the catheter and leave the catheter in once you put the needle in, take the needle out, leave the catheter in until the patient can get to the hospital, and we can place a chest tube in as well. Okay, so you did your A's, your B's, and now C's. I should have put circulation is what the C stands for. But essentially, when it comes to trauma, what we're talking about is bleeding, especially at the scene. If there's any obvious bleeding, then you want to work on bleeding control, because the first thing is going to be this patient's going to probably have clothes on. You may not necessarily be able to see where they're bleeding. You don't necessarily have to do a full exposure in the field, but if you can tell where they're bleeding from, you want to try to get that controlled as well as possible until you get them to a surgeon. And there's a couple of different ways to do that. Direct pressure is always important. If you have hemostatic agents like what's called Quick Clot, which is a brand of a hemostatic impregnated cloth, which they do have in some of the Stop the Bleed kits, or even just anything that you can use, even if it's just a t-shirt. We tell bystanders that we train, they can use anything if they don't have anything else available, but holding direct pressure. And what that means is a lot of times people will, and you've probably seen this, go like this and hold pressure like this, and that doesn't actually hold pressure on the blood vessel that is bleeding, especially if it's an arterial bleed. You want to hold as focused pressure as possible. If you can use a single finger, that's optimal. If you can't, then just 2 or 3 fingers, but you want to hold direct pressure onto the vessel. If it's a venous bleeder, it's going to be a little bit harder to control that pressure. If you have something to pack into the wound, that will be helpful to help tamponade off that bleeding. Tourniquets are also very important if you have those available. There's different types of tourniquets. There is, here it is. A CAT tourniquet is what the ACS Committee on Trauma recommends if it's available, just because it does give you the best bleeding control. But the keys to that are that you want to put the tourniquet on proximal to the area of bleeding. Sometimes you may need 2. And it's going to hurt. If they're awake and it's hurting, that's probably good, that they're still with you and that they're not in shock. You tighten it until the bleeding stops. If the bleeding doesn't stop, you put on a second tourniquet, more proximal, and you tighten it until you can try to get the bleeding to stop. And you won't feel a pulse distally. You're not supposed to feel a pulse distally. That's okay. If you are able to, the first question that I as a trauma surgeon always ask is, what time did the tourniquet go on? Because that affects what I do in the operating room. If you don't, completely understand, but I do like to ask because, like I said, it will make a difference for the patient. The other part of circulation, so again, scoop and run is still the preferred way to do things if you're able to get access. Large bore IVs are better than any kind of central line that we will place in the trauma bay. That's what we prefer. We'd still, if they don't have an IV in, we still have the nurses place the large bore IV. We can run products and fluid and blood in through those the fastest. We don't place the triple lumen central lines anymore for traumas. Sometimes we'll place a cordis. If you're able to get intraosseous access, that is also preferred. We can run blood transfusions through intraosseous access. We can get labs off of intraosseous access. So that is also very helpful. Even in hospital medical codes, it's now preferred to do that over trying to get a central line, which we used to do, because you have to stop everything else and try to get this central line in, and you can't even run blood products in as quickly. So those are really preferred if you're able to get those. So pitfalls, which is something we kind of reviewed at the beginning, but again, don't rush. Make sure that you're taking care of yourself, that you're protecting yourself, that you're not causing any further injuries. You can certainly cause additional injuries. I had I once saw somebody opening up a chest and just got really slash happy and also hit the lung. So just know that you have to calm down and not rush and make sure that you're doing this correctly, because otherwise it's just going to make it longer and harder after that. So don't forget about your own safety as well. Try to, again, within constraints, get the patient as quickly as possible to definitive care. Remember your spinal precautions in the background of everything. Again, not for penetrating injury, but for blunt injuries. And when in doubt, have a high suspicion for injury. A lot of times we can get jaded, and you can just have an angry, combative patient who had a gunshot wound to his thigh, and he's just being a complete jerk. But he may have a femoral artery injury, and he may just be in shock. I've actually seen people, they can be in shock, and altered mental status can be the first thing that manifests. So just remember and just have a really high suspicion for potential injuries wherever you go. Elderly patients that just fell, they could have a bad high C-spine injury, they could have a bad head bleed. We see that very frequently, actually. A lot of times because they're also on whatever antiplateletation, anticoagulants, etc. So trauma arrest, until and unless proven otherwise, and sometimes even still, trauma arrest is due to bleeding. It is always due to bleeding. If you can't see the bleeding, it's intra-abdominal, or it can be in their thigh, it can be in their chest. So that is always what it's due to. In the past, similar to kind of medical codes, part of the ACLS protocol was to give epi, and I don't know if you guys have heard that that's not so much in favor anymore for trauma. The main thing being because a trauma patient is bleeding because they don't have anything in their tank. They don't have enough blood, and so giving them epi doesn't actually give them what they need. It doesn't actually fill up the tank, and so you're just trying to restart the pump without actually giving them anything to fill up their tank. So the first goal is getting access and giving fluids and blood and getting them to a place where we can give them a massive blood transfusion. And then also, if you do have a trauma arrest patient, do consider that they could have a tension pneumothorax, and so bilateral needle decompression is typically recommended as well. Okay, and now just for fun. So if you do have that trauma arrest patient that comes in, which one of those patients is going to actually get their chest cracked open when they arrive to a trauma center? The best option for that, the patient that's going to survive that, is a young, healthy trauma patient who has a penetrating injury, who has a stab wound in the cardiac box or in the center of their chest. Because they typically just have an isolated cardiac injury, tamponade, you can open up their chest and fix it, sometimes even just in the trauma bay. So if you have somebody who's been coding, who's been stabbed in the cardiac box, which means they are in anterior chest, in the middle of their chest, they've been coding for 10 minutes, you got to the scene, you were getting them all prepped and ready, and then they coded in front of you, you've been coding them for, I don't know, 12 minutes in the hospital. That would be somebody who would have the highest likelihood, by that still less than 10% chance, of survival. Gunshot wounds are less likely, higher velocity, far more likely to have more devastating injuries. Blunt trauma, very low likelihood of survival. And you have to remember that similar to the first slide, these are high risk also for the care team. I have a lot of chest opening stories, I guess. I watched somebody open up a chest and decide that the ribs were in their way, and to break them, use their hand and cut their hand on the ribs that were broken, and had to go take medication for a few months. So remember, this is also a high-risk population sometimes, and every procedure does have its risk both to the patient and to the provider. Let's see if this works. Here's just a fun little video I have. This is a real-life thoracotomy that I did in the ER when I was a resident. This patient had a stab wound. He lived. He walked out of the hospital. My attending decided it'd be fun to pull out his phone and take a video instead of scrubbing in. But yeah, he had one of those great injuries that he was able to survive because it was just a right ventricular stab wound. It didn't go too deep, so he could survive that. He coded for less than 15 minutes. He met the criteria. Okay, so that's all your trauma assessment. You've done all of that in the field. So now talking about trauma consultation. When you're when you're talking to either a nurse or a physician at a trauma center, we're going to want to know obviously the basic demographics, the age, the gender, the mechanism, vital signs, and whether that be stable or unstable, or the patient is tachycardic, or an exact blood pressure. Any or all of that is helpful. And particular needs or concerns, like I put a tourniquet on, or we had to intubate this patient, et cetera, so that we can be aware and ready. Typically when we know that a trauma patient is coming in, there's various different levels at each hospital of activation. So some hospitals may not necessarily call a respiratory therapist for every trauma, but if you know that you intubated this patient, that way we can have the supplies ready and available to hook that patient up to a vent and get them back, et cetera. So any kind of key issues like that are helpful, and then obviously ETA and that sort of thing. When you arrive at the facility, what is the trauma team looking for? Again, it depends on the facility, who is available, and what level of trauma activation each facility has, which varies by facility, but is fairly similar. Essentially, the goal of our trauma activation is to assess how sick the patient is for you and how likely they are going to need to go to the operating room or need a surgeon or need to get intubated, et cetera. Because each one of those trauma activations calls a different group of people, whether or not it calls the blood bank or the anesthesiologist or even the trauma. We have 2 levels of activation at Sinai, an echo code, which calls the ER, but I as a trauma surgeon would not necessarily respond to that. But if it's somebody that may need to go to the operating room, or has a head bleed, et cetera, they would activate at a higher level to get the trauma surgery team down there, as well as the ER. So just be aware that what you guys report out in the field will affect who's there upon arrival to help the patient. That being said, things can always be escalated or de-escalated whenever the patient arrives, but just so you know how we're using that information from the hospital side. So again, the basics, the age, gender, the mechanism, MVC, pedestrian struck, et cetera, high speed, low speed. Any relevant details like extrication, how long the extrication was there a lot of intrusion, was the passenger dead on arrival and this is the driver, if you know whether the patient was restrained or not, or ejected from the vehicle. All of these affect our level of concern for various different types of injuries. And so sometimes, you know, I stick around, I can go find out what CAT scans I feel like I'll need, or what kind of injuries I have a higher or lower suspicion for. Vital signs, again, as I mentioned, GCS, if you're able to get it. GCS is a great prognostic tool. Technically, the best level of prognosis from a GCS is actually after resuscitation, so it's after their arrival, and if we get them resuscitated if they need it. But I think it's still helpful to see if there's any change, especially if there's a deterioration from when you saw them at the scene to them arriving to us. We had a patient like that a few months ago who got in a car accident, was GCS 15 at the scene, arrived to us, and literally in front of us and the paramedic who was standing there, significant drop, and we had to intubate her. So that kind of affected what kind of injuries we were worried about. Any obvious injuries noted, obvious deformities, bleeding, et cetera, and again, any interventions. So I put an IV in this arm, et cetera, I gave this much medication for this, or fluids. And if you have other information about their medical history, like say you had to intubate them, but there was a family member there who said, oh, by the way, this patient is on Coumadin, that is always helpful. I know you don't always have that information, but if you do, sometimes we're not able to get it if the patient's family isn't there, et cetera. Glasgow Coma scale, for anybody, if you're not familiar, GCS, which is the GCS that I mentioned earlier. This is just kind of a very basic neurologic survey that we use in our primary initial survey of a trauma patient. That is a good kind of objective way of communicating between healthcare providers at the scene or at the hospital, or between us and the neurosurgeon, how a patient is doing. And like I said, it can kind of gauge whether initially you saw a patient and say they were moving their arms around totally normally, so they had their best motor response, they had their eyes open spontaneously, they were completely oriented, and then when they arrived to us, they had some clear change there. And that makes us more concerned about a traumatic brain injury. So all of these together, when you add all of these together, you get 15. 15 is the best GCS that you can have. If the patient is a little bit confused, there'll be a GCS-14. That's a mild traumatic brain injury. If a patient has absolutely nothing and are completely obtunded, they still have a GCS of 3. It's never a GCS of 0. It's still a GCS of 3. And then again, just depending on how they do as far as their eye response, et cetera, that'll kind of tell us how the patient is doing from a neurologic standpoint. The other thing that is important to note about the Glasgow Coma scale is that anybody with a Glasgow Coma scale of 8 or lower has a significant or a severe traumatic brain injury, and that patient is not adequately going to protect their airway. That person gets automatically intubated. So an example of a trauma consult, say when you arrive, if you're just telling us what's going on with the patient, you would just say that this patient has a single GSW to the back, a 25-year-old male, they're responsive, GCS 15. They were a little bit tachycardic with a normal pressure. You don't have to give me all of the numbers if you don't have them. But just saying normal pressure is helpful, or not a normal pressure. I had to give him a liter of fluid and then it got better. Decreased breath sounds on the left, so you needle decompressed, left the catheter in, and you gave him a liter of LR through a 16 gauge. And that's just kind of quick and dirty, and it tells us everything that we need to know about the patient, all of the important pre-hospital procedures or interventions that happened, so that when we're giving them a second liter of fluid, or if you already gave them 2 liters of fluid and they're still hypotensive, we're aware of that, and we're not trying to give them 2 more wondering why they're not improving. And also knowing that we need to try to get another large bore IV, et cetera. It just kind of helps us get the patient taken care of in a more expedited manner, and kind of streamline the whole process. Similar here, so that if this would be a blunt injury, an MBC. So this mentions a little bit more about what you saw at the scene, but again, like I said, that helps me figure out what I'm concerned for as far as injuries, because they have a much higher risk of mortality if there was somebody else who died at the scene. If their airbags were deployed, they're more likely to have a cardiac contusion or a sternal fracture, or rib fractures, etc.
I'm curious about something. You use the term vitals are normal. I first think about that, and the argument would be if you have a morbidly obese person whose blood pressure normally runs 170 over 100, and yet they have a blood pressure of 120 over 75.
Yes.
It may be within normal for a normal health person. So I know that some people downtown are pretty irritated actually
to your normal. Yes, and the word that I specifically didn't use irritates me more, but yes, I mean that does make sense. Yes, so the question was, sometimes normal doesn't necessarily mean normal for the patient if the patient is significantly hypertensive, or if they're a little frail old lady, and a lot of times you'll see their blood pressure is 90 over 55 and they say, well, that is always my blood pressure. So normal doesn't mean normal for everybody. So you could say a blood pressure is normal and that is not necessarily the case. So that is something to keep in mind. So there may be some places that prefer that you just give them the number. I personally wouldn't get mad at you for that. But one thing that does bother me actually is stable, because stable could mean that they're still 60 over 30 like they were 30 minutes ago. And that is not, that's not what we mean when we think stable. That patient is still in shock. So that is something to kind of remember. When in doubt, you can, just saying that the patient has a heart rate of 134 is better than saying a little tachycardic, because a little tachycardic is different for you than for me, and et cetera. But yeah, that kind of depends on who you're talking to and where you're going. So. Yes, so any other questions at all?
What does the trauma service do, or your thoughts about nasopharyngeal airways with potential patient injuries?
Don't use them.
Don't use them.
Yeah.
I'm pretty sure that's
the nasopharyngeal airways, which can be very helpful, but if the patient has apparent facial injury or head injury, avoid them, because they could have a basilar skull injury. You could exacerbate in the wrong place.
Could you, from your perspective, delineate a little bit when you want to get a patient versus when you want the patient to go to primary care center?
Yes, excellent question. So level 2s and level 1s have different capabilities. A lot of them are similar, but there are certain specialties that certain hospitals don't have, which I believe you guys probably have a list of, but I think Union Memorial is the hand specialist. But essentially it depends partially on where you're at and how quickly you can get to a definitive center. The main difference between a level 2 and a level 1 is that we don't have an in-house neurosurgeon. But as far as the actual trauma goes, most of it, if you have a gunshot wound to the abdomen or a stab wound to the chest, etc., all of that stuff can be managed at a level 2. So we are comfortable managing that. Again, if it's like an amputation, I think that would be that would need a specialty facility. Yeah. Anything that you guys want to add for that, Sean or Scott?
Say it again, I'm sorry.
When you would go to a level 2 versus level 1, there's certain capabilities, mainly at the specialty centers, that we don't have.
I don't know what
but
so I defer to that. My sense is I'm not sure.
Right, so you do a trauma
Yeah.
consult, get both facilities
Yeah.
online. If it's a questionable whether you should go to a community hospital versus a trauma center, definitely err on the low side of a level 2 trauma center. Your transport time should be one of your biggest deciding factors. Airway management should be another deciding factor. I'm hard pressed for me to go past Sinai and run down the shock trauma. If I can't manage it, my patient's blood pressure, anything, or there's something else I can't manage on the patient. Then the other question is, can they handle it? Sinai has been off the charts busy with just on normal days, even recently it's been a little crazy, but you consult ahead. They may not actually have the ability to take that. And they had, I put my father in the hospital last week, they had 5 gunshot wounds within about a 2-hour period. Hospital on lockdown twice, I'm sitting in the ER. That's just another day at Sinai. So again, that's why you consult ahead, because at that point they weren't taking any other complications.
I talked about level 2 and level 1, but yeah, there are some facilities obviously that are not trauma centers at all, that are community centers. And so if you have a completely unstable patient, then yeah, take them there, but otherwise do try to take the patient to a trauma center. But yeah, if there's a hospital nearby, your patient is coding, don't skip over that hospital to go to a trauma center. Yes?
First comes up in confusion always is when you have somebody, a pelvic or femur fracture, used to be taken to a trauma center, then they came down later, taken to a local hospital, from hospitals, Baltimore hospitals to be cleaned up. What is the preferred place for them for the best outcome for the patient? Trauma center?
Trauma center, yes. Because a lot of that depends sometimes, which you guys shouldn't have to worry about at the scene, is the specialty services like the neurosurgical and the ENT and the ortho, who are a phone call away and they're a consultant and they have their PAs go by and look. But so that depends on the hospital sometimes. But ultimately, a trauma center has kind of a multidisciplinary approach that will be able to better take care of that patient in the long term than necessarily a community hospital that maybe has an on-call orthopedic surgeon that can handle a pelvis, but they don't have the other community of resources that a trauma patient necessarily needs.
My sense is that there's a lot of risk aversion for the community hospitals. When I listen to consults, a lot of community hospitals, if there's any other trauma, yeah, we don't want it.
Yeah. And we often get transfers in, like from Carroll County. We get a lot of trauma transfers in from Carroll County, which is fine. They're one of our sister hospitals as well. But
What do you see as the area that pre-hospital care providers need to work on the most to maximize case outcome from your perspective?
from two things, I think, and you may already be meeting these, I'm not quite sure, but number one is trying to get the patient as quickly as possible to definitive care. So if you can get them in to where they need to go within 10 minutes. And then number two, again, this depends on the provider and depends on the trauma center as well, but being able to get kind of a smooth handover of the patient. And hopefully you have a trauma center that is asking everybody else to quiet down so that you can give us that report, because I know that sometimes that's difficult and it's chaos in there and you can't actually find out who's in charge and who's trying to listen to you, et cetera. But just trying to make sure that we get information as quickly as possible and get the patient moved over and taken care of so that we can start the rest of their care as quickly as possible.
I know the EMS office has been talking a lot about time on scene for traumas and using that 10-minute cutoff and reaching out to providers who don't quite meet that 10 minutes to understand what's going on. I think there's a lot more emphasis in not on discussion I've heard.
one big question. You might have a photograph that seems useful from a medical perspective.
I find it interesting, but unfortunately, actually, to be quite honest, no. If you tell me there's significant intrusion, I'll believe you. So, any other questions before we start the practical portion?
Do you want to take a couple minute break? And
Yeah.
then have both of you want to guide us in terms of what's going to happen next?
So afterwards, we're going to take a quick review of the trauma decision tree. We'll put a patient up front and we'll go through a rapid trauma assessment as we would normally do in the field. And then we'll probably break into a couple different groups. I'll see if Coach will help us do some consults, get a couple radios, and we'll have Dr. Q watch as you guys go through and do some trauma assessments on different patients and kind of help us make some decisions as we go through and assess, and she can kind of give you guys some heads up on what we should be focusing on and the information that she wants to get from us and how to best do that. So that'll be our next, give it a half hour or so. So be back in your seats in 5 minutes. There's a restroom here, go out the doors to the left, restrooms there as well, and water machines on the restaurant. All right, so let's do a quick review of the trauma decision tree. Why do we use this? What's the primary use for this? What does this allow us to do or not do? So communication, who wants this information? We got to communicate it from the field to the hospitals. Who else wants this information? Medevac. So this is your mechanism for triggering whether or not you're going to get a helicopter or not. So, Category Alpha and Bravo. If your patient meets one of these criteria and you let dispatch know you have a priority 1, Category Alpha or Bravo, you can have your helicopter without having to consult with the physician. Is everybody familiar with the EMRC and the state police and how this whole thing works? So you have the EMRC folks that are sitting upstairs at MIMS. In that same room is a state police sergeant. If you guys consult in the field, they're listening for the doc here or one of her counterparts to make a decision based on what you tell them whether or not they're going to approve the use of that helicopter. So 30-minute rule is the start, and then they have to sign off on it for you to actually get it. So category Alphas and Bravos are probably going to die or come close to it or try to out in the field. So we have a GCS of less than or equal to 13, systolic blood pressure of less than 90 in adults, 60 in peds, respiratory rate of below 10 or above 29 for adults, or less than 20 in infants, ranging less than 1 year of old. So if we do have this, and especially if they have a rapidly decreasing GCS, what's your next treatment? What's the only thing that's really going to fix this in the field? We're really going to fix it in the field, but what's your only real shot at trying to address this? A rapidly decreasing GCS. Why is it happening? I'm thinking brain herniation. So if that's what I'm thinking is going on, then what's my option? I got one. I'm also a BLS provider, so let me rephrase that. What's my option? Oxygen. Bag them once every 3 seconds, right? You got a hyperventilation protocol. That's about it. Where else do they need to be? They get a trauma center with somebody drilling a hole in their head. No, we cannot use the one off the squad. We've asked. But that's what they need, right? So there's not much I can do in the field.
So when you say trauma center, they need to be downtown at shock trauma or Hopkins level 1. So again, with the neuro on call, have their neuro on site. The center does not. Is that correct?
So we have neuro PAs. So actually, yes, this patient you could bring to a level 2 center as well. They would be able to go urgently to the operating room.
We'll pause on this since you bring that up. Let's run through our specialty centers. So the hand centers where? Union Memorial. So you got Curtis. Tell me about Hopkins Bayview. What's their specialty? So burns for who? Adult burn center. Okay. So if you got an adult patient that's got burns and trauma, where are they going? They could go to Bayview because it's also a level 2 trauma center. So in addition to burns, it is a trauma center. So absolutely they could go there. If I'm coming from here and my patient has burns and associated trauma, where are they going? Shock trauma. I'm not going to pass shock trauma just to get to the burn center. I will consult, but shock trauma is more than capable of taking care of burn patients. What else does shock trauma do, since we're talking about them? So they're your primary center for what? They're a park, a primary adult resource center. There's only a few of those in the country, right? So they can kind of do everything in-house. So in your Maryland protocols,
they're called a PARC. So they essentially we almost get a shot of first refusal. So your major significant ones should try to head down there. Consult, and how do we get a doctor on the line down at Trauma Center? What words do I use to EMRC to make sure that I'm talking to the right person? A trauma line consult. If they hear that terminology, the next voice you hear over that radio is the doc picking up one of these because she's walking around with this, and she's going to start talking to you right away. We're running, Sean. We're good. So trauma line consult. What else does shock trauma do? So you have hyperbaric, we have neurotrauma, primary adult resource center, any patient over the age that's reached their 15th birthday or older. What other special centers do we have? What does Hopkins Downtown offer us? What level trauma center are they? It's all level 1. It's also your what? It's also your primary pediatric center for the state. What else do they offer? There's more? Eye center, yes, Wilmer Eye Institute. So anytime we're going to a specialty center, we need to consult from the field. And the doc went over a good consult and make sure that you're able to paint that mental picture for her while you guys are out there. So they hear category alpha, they know that your patient's in pretty bad shape, they know they got to get them down to a trauma center pretty quickly. Bravos, your patient's also in significantly bad shape, so these are some pretty nasty injuries, 2 or more proximal long bone fractures, so bilateral femurs, amputation proximal to the wrist or ankle, chest wall instability or deformity or a flail chest. How do we fix that? BLS level, how do we stabilize that? Packet, so trauma pads, I'm a big fan of the 1000cc IV bag if you have one. A couple of Y cravats there, hold everything in place. ALS, anything else you might want to consider, depending upon the cause? Is this the time you guys will pull out a needle perhaps, or at least consider it? So consider that. Crushed, degloving, mangled, or pulseless extremity. So what's a degloving? I've only seen one with that man right there. That was pretty nasty. Guy on Ridge Road, met the car coming around the corner. Remember that? That's nasty. So what's a degloving? All their skin on this guy's arm was pulled all the way down and was just hanging there. Everything else was completely intact. So that's pretty nasty. What do you do for that? Trap it. Not much you can do for them. Wrap some trauma pads around there, go to the hospital. Do I need to try to reestablish a pulse in this pulseless extremity? Maybe. If it's isolated, I'll consider it, but this is part of an overall big picture, multi-systems trauma. So no, I'm not really worried about that. We need to go to a trauma center. Open or depressed skull fracture, penetrating injuries to the head, neck, torso, penetrating extremities proximal to the elbow and knee, so stuff in close to the body. Pelvic fractures. So even your patients, the 90-year-old grandma that falls down on carpeting complaining of a hip or a pelvic injury is a high-level trauma. And as the doc said, absolutely, they go to a trauma center. And you're right, so that's a very big deal. And when I take my classes to the trauma center, that's one of the big things they do continue to beat on is bring us these elderly patients, because for these people, they may never walk again, or may never walk again on their own the way they used to, and it could be a very life-changing event. So rather than sitting in a community hospital for 6 hours, not having a surgeon there to fix them, as compared to a place that can fix them, is a very big deal. So any of these Alpha Bravos, if you can articulate that to the dispatcher, then you guys will get your helicopter. Category Charlies are going to be more of your mechanisms, so high-risk auto crash, 12-inch intrusion on the occupant side, 18 inches anywhere else, ejection or partial ejection, death in the same passenger compartment. So I've had them where driver's dead, but the other ones are out walking around. If there's enough trauma to kill the driver, everybody else, or anybody in that vehicle, everybody else goes to a trauma center, just because. If you look at the vehicle and you're like, wow, how'd you get out of that? They should probably go down to a trauma center. That puts them in the category, or at least Delta category. Roll over without restraint, auto versus pedestrian, usually greater than 20 miles, or an hour, or a motorcycle crash greater than 20. Deltas are going to be more of like your comorbid factors. So things like age, below 5, above 55. Systolic blood pressure of less than 110 over the age of 65 could be an indication of shock. But again, look at your patient's big picture. Low impact mechanisms that could result in severe injury. So again, that's your old person that falls down and hurts their hip or pelvis. Burns without trauma mechanism, go to a burn center. With trauma mechanism, go to a trauma center. Pregnancy greater than 20 weeks. So that's not a sickness, being pregnant. It's just a condition. So anything higher than 20 weeks, where would I want to take my patient? High risk. Options. High-risk pregnancy, where am I going?
The facility where they plan to deliver?
Maybe. Depends on where their facility is. So let's talk about that. That could be one. But legitimately, in my world, I'm going to go to one of two places from here. Going to Sinai, most likely first, and who am I going to consult with to see if they want them? Hopkins? But I would like to just go to Sinai with them, in all honesty. But again, when you're questioning that, because I say that because Hopkins is the high-risk pregnancy place. So again, where could they deliver, and then where can I get them? There's your EMS provider judgment. So if you just think they should go to a trauma center just because you think so, take them. And then any kind of anticoagulants or bleeding disorders. So if your patient's unconscious, unresponsive, you may not have a lot of this information. So you may only be able to go with your assessment. And that's why the assessment's so key. And that's why we focused on this training tonight, because if you don't assess your patients properly, your treatment's going to be pretty horrible because you're not treating the right stuff. So let's run through a rapid trauma assessment the way Dr. Ritz and I taught in class last night. All right, so we come into the scene, primary assessment. What are the 15 things we need to be concerned about? Calvin, you're fresh out of class. Where do we go? What are we doing here? First 15. Scene safety. Yep, put your rubbers on. So mechanism of injury. So right off the bat, you may be able to not even get out of your vehicle. I pulled up on the call with the motorcycle accident. I can see a femur sticking out of his leg. Do I have enough information to call for ALS in a helicopter? Yep. So some stuff you don't even have to touch your patient. You may be able to just visibly see based on what you guys, when you roll up. All right, so mechanism of injury. What else? Number of patients, and that directly affects our need for resources. Now is the time for you to call for a helicopter. If you go through your entire trauma assessment, start packaging and decide, oh, I want a helicopter. Why? You've wasted 10, 15 minutes on scene. That's how long it's going to take for them to get there. So if you want that helicopter, you need to call for it now, which also means I got to consult for it now. And I really haven't even done a trauma assessment. So that's for the delicate balance where you guys have good provider judgment to make that decision. All right, when we go to mechanism of injury, what else has to be decided right here, right now? C-spine. So we got to make a decision. As the doc said, if he has a single gunshot wound to his chest, do I care about C-spine? No. Will I use a backboard to move them? Maybe, but it's just a lifting device. It's not true C-spine, right? So we got to make a decision now, and that puts one of the providers out of service because that's all you're going to be doing is holding C-spine, correct? So now you have the other provider that's got to go through and do your rapid trauma assessment. All right, so take it from there. Those were the first 5. What are my next 5? So a general impression, be able to articulate that, and again, now you're starting to set the tone for the doctor of what they're starting to see in the field. Because if you want to get permission to do advanced skills or call for a $10 million helicopter, if you sound like a moron and shouldn't be touching this patient, they're going to say, no, just bring your patient to me, don't do anything else, and just come to a hospital. But if you guys can articulate what you see in the field and let them know that you have a half a skill set, then they'll let you go out and do some more things in the field. So after we do our general impression, we assess their AVPUS. That's when we're going to come up with my GCS. So they alert, and being alert means they're alert to what? Daytime, place, and self. So alert and oriented times 4. If they're not alert and oriented, they may respond to a verbal stimuli, painful stimuli, or unresponsive. All right, at that point, I can move on to what? What are my last 5? Is my patient alive? So CABs if they're unconscious, unresponsive, ABCs if they're talking to us. So grabbing 2 pulses, carotid radial, depending upon the age of my patient, staring at the victim's chest rise and fall 2 to 3 times in 10 seconds, and discoloration. Lips, fingernails, general cyanosis. If I note cyanosis, what does that tell me? And they've been without oxygen for several minutes. And so is that pretty key that we need to focus on the airway? All right, so CABs. Once I get to this point, do I continue my assessment? Would I need to stop my assessment at any point along here? If I recognize my patient stopped breathing, for example, is bagging my patient always the right thing to do next? Yes. Why are they not breathing? Especially if they got a hole in their chest, and especially if it's something that's affecting their lungs, and I just start bagging them without putting any kind of seals or dealing with it on the outside, am I actually affecting the airway? Yes, in a very negative way. So I may have to break strides, sucking chest wound, evisceration, if he's got an amputation, the blood's actually squirting out. Very few things I have to stop for, but airway things, as you said, you're quite correct. Unless they're bleeding out, I should start bagging my patient right away, and that's critical. Start getting air in your patient if they are hypoxic. So D is a dense bleed sweep. So I'm coming down my patient, constantly pulling out my gloves. Like Doc said, your patient's wearing a lot of clothes, you may not see any of the blood. So pull your gloves out and just look for any of the blood. If I find blood as I'm coming down here, I need to do what? Get them naked. So start getting their clothes off, find out where they're coming from.
Not make them naked from the very get-go. If they're a critical patient, I get a pedestrian stroke, they're still laying in the road when I arrive to me, that's a critical patient.
Absolutely.
They got the hell up and forget again. So with that, I'm going to assess the patient here to be naked. I'm not there to have sex with them. I'm going to identify what it needs to be.
No, I'm with you. So you do your A, B, C, D. So stay with me. Do your dense bleed sweep to find any critical life-threatening bleeds. I'm down here at their feet, right? Grab your trauma shears, and I'm with you. You got to make them E. Before we start our assessment, they need to be completely naked. I'm with you. This is all, I'm taking time to talk about this, but I'm with you. This is about 30 to 45 seconds of me doing all this. As he says, you got to get them naked. It's trauma. You cannot treat what you cannot see. Bruising is going to be a very big thing, and very early on, you may not feel anything abnormally hard or mushy, right? So that bruise may be your first indication. So yes, and when they get to the trauma center, they really shouldn't be playing with their clothes. They should be dealing with the body and everything else we can do on our time. So get your patient completely naked. Now we're going to do a head-to-toe assessment. So we're looking for what?
You want to address exposure in a hypothermic condition.
So I'll let you do that. Go ahead.
If somebody's lying on the street and it's the middle of January, you have to close off the middle of the street in order to do your assessment, or put them in the back of the hot medic unit or warm medic unit and do your exposure there. And I would suggest that probably the second is a better option. Hypothermia is a major problem in trauma patients and causes coagulopathy and all that kind of stuff. So.
Yep, he'll jump a little ahead because we're going to talk about that once your patient is naked, because the space blankets, we need to use those a lot more. Because like I said, your patient's body temperature drops just a few degrees, the clotting process isn't what it's supposed to be. And so that majorly affects your patient. So just wrapping that space blanket around them and oxygen is going to actually do quite a bit of good. And if we can get IV access with a little bit of fluids would also be helpful. So I'm going to look for DCAP, BTLS, lumps, bumps, and bruises. Starting on the top of the head, work my way around the back of the head, individually feel the vertebrae, feeling for what we call a step off, so you feel something weird and out of place. Come back around, top of the head, pop open the eyes. I don't even use a pen light at this point. What am I looking for in the eyes? Two quick things that just popping their eyes open are going to tell me. Are they equal, and are they at all responsive to the little bit of light that they do see? If I have a trauma patient and unequal pupils, where's my head going? I'm thinking there's some sort of a head trauma going on in there, right? So that steps it up. Or if they're both pinpoint, what does that tell me? I'm thinking there's a narcotic on board. So could they have been high and wrecked their car? Or could they have been high and stepped in front of a vehicle? So it doesn't mean that there's not multiple things going on here. So I like looking at eyes. They tell me an awful lot. If I saw two dilated pupils, what does that tell me? So I'm thinking more ecstasy, stimulants, but there's definitely something going on if both of their eyes are affected like that. There's something else going on inside. So now I need to just keep a higher index of suspicion. Check the eyes, under the eyes for what? Bruising, so the battle signs, and then under the ears for the bruising, the same thing. So when she talked about not using the nasopharyngeal, those are the couple of things that we're looking for. Press around the face for stability around their cheek. If all these things are normally, we don't have any of those signs, and it's not a significant head injury, then your nasopharyngeal becomes an option. But you've got to absolutely make sure, she said, there's absolutely no signs of a basal skull fracture. Any suspicion, you wave off, do an oro, or just manage the airway with head positioning. If the paramedics get there and they have the ability to intubate, then they can go ahead and do that. And when the troopers get there, if all's not going well, the troopers have the RSI, the rapid sequence intubation. They can basically knock your patient out, paralyze them, and then take over their airway and manage it for them. So lots of airway options. Just got to get the right people out there to do that. So we're checking for fluids. If I have fluids coming out of their ears or nose, do I need to shove stuff in there? Do I need to pack that wound? Worst thing you can do, no. Just catch the fluid, be aware that it's coming out. All indications of basal skull fractures. Assess the mouth, make sure they are still breathing adequately. Check for their teeth to be in place. Elderly people, dentures in or out? In. As long as they're not a hazard, leave them in. Better facial structure, better get a better seal with the mask. Everybody had a chance to play with the mask in the back. If not, go see those guys after class. Come down, I'm checking the front of the neck for 4 things in particular. What are they? Down the center of the throat, what am I looking for? Tracheal shift. What else am I looking for? What's on either side I'm looking for? Jugular vein distension. Is that an early or late sign in most of these injuries? tends to be a later sign, so may not some of these patients. What other two things can I look for? Are they a neck breather and medical alert tags? So do all those, establish, palpate their shoulder and clavicle, and at this point slap a collar on. Why do I want to put a collar on now, even though I've only assessed 10% of their body? Because I suspect a cervical spine injury. If I move that spine around, does it take a whole lot of movement, doc, for me to cause permanent injury? So if I really think that their neck is screwed up, take the time to put a collar on now, because especially if it's a hose beater sitting up here, or a firefighter holding this, we got the attention span of my puppy, right? So we're going to be looking around doing this or that, so the head's not going to stay put. Put the collar on, help the hose beaters out. So now we're going to come down, now we're going to check the patient's chest. Gentlemen, women have these things called boobies. It's okay. Put your hand right down the center of the chest, check for stability. If your hand goes down the center like this, you're not doing anything inappropriate. So check for the stability of the chest. Bring your hands around their chest wall, thumbs meeting in the center. Spread your fingers out. 2 good breaths up and down. Do we feel flail chest? Do I got good equal rising and moving of the chest wall? Grab your stethoscope, mid-clavicular, mid-axillary. All I care about is, do I hear equal sounds? Do I hear any sounds? And if so, and if there's something weird going on in there, do I care between rails, rhonchi, anything else? No. Tell the paramedic or the doc, I hear something weird in the lower part of their left lung. I don't care. You don't have to be right. Just tell them there's something weird. Let them figure out what it is. At that point, we're coming down to the belly. So for the millennials in here, go Google what a typewriter is. And there's this thing that kind of moves back and forth we used to use before computers. But I want you to be a typewriter. I want you to slowly use your fingertips and palpate all the way back and forth across their belly. Looking for bruising, but feeling for things extremely rigid or extremely soft, or things that just don't feel normal. That's why in ENT class we had you guys doing all the poking and prodding. Check pubis symphysis next. If that's an issue, then we can stop the pelvic assessment. If that doesn't cause any pain, we can gently push in, gently push back. Again, if we feel things moving, shifting, grating, stop the pelvic assessment and move on, because you already know that there's an injury. When you come down to the femurs, if one's noticeably deformed and you know that you have one femur injury, leave it. I know it's injured. I see it. Got it. Check the other one. Because if I got bilateral femurs, what am I not doing? Not putting hair traction splints on, right? Now, here we do carry the Sager, so we could legitimately, during transport, put the Sager device in here and do bilateral femurs. But your patient's got bilateral femurs. Is this significant? Are they bleeding out in front of you? Could one of these femur injuries cause enough blood loss for them to go into shock and die from that? Right, so if they got 2 of this is pretty critical, so I'm not really playing in the field at this point. Check the rest of the legs, check for pulses. Check the arms, check for pulses. They don't really die from extremity injuries, right? Unless they're at least arm injuries, unless it's bleeding out. At some point, we'll have to roll the patient, check their back, check their butt, get them onto a backboard, make sure we're putting cushion between the backboard and the patient, because even for a short period of time, us putting them on that backboard, especially for elderly patients, could actually be pretty bad. Those weird folks, I mean, in Pikesville, we got a lot of old people here, so they got all these weird shapes and contortions, so make sure you pad that for comfort. They could be on that board for a little while. They are pretty quick when they get them in the ER, doc, right, about trying to get them off the board, because you guys really don't want them on there unless it's absolutely necessary. And if it is necessary, they're staying on the board through x-rays, CAT scans, and other stuff, correct?
Yes. Well, I don't typically keep them on at all. Because you can still keep inline stabilization of the spine even without the backboard. So we still keep them if we need to, if we're suspecting a TML spine injury. We still keep them immobilized, but just without the backboard.
At this point, notice what I have not done. I haven't taken a set of vital signs yet. I grabbed 2 pulses. That's the only vital signs I need. If my patient's got a good carotid pulse, what's their systolic blood pressure? 60-ish? It's got good radial pulse? 80-ish? So I can at least check my patient's hemodynamic stability right off the bat. Don't really care about a number, right? Because nothing's going to do is going to affect my treatment. If I eventually get a blood pressure, it's below 100. If I got an IV tech in here, what are we doing? Start a large bore IVs, titrating to 100 systolic. Again, it's all got to be, look at your patient. If the patient's got history of issues with their lungs and fluid retention, we may have to talk to the docs before we start dumping lots and lots of fluid into them. What did I miss?
I would say, yeah, I agree with you. Be careful with exposing a patient completely. And if it's taking you too much time, if they have a belt on, etc., don't worry about that stuff.
So a lot of this stuff can be done in the ambulance on the way down to the hospital. Don't forget to pull these out occasionally and use these things. We don't drill with them a whole lot. I know you guys went through TAC 29, but these are kind of useful. We still have triage tag day to pull those out, use those. It's also a good reminder as we're kind of going down, looking for all the different types of injuries. Questions, comments? Anything I missed? All right, so here's what we would like to do. We have a patient, Meredith volunteered to prop herself up with a whole bunch of stuff. So let's get a group in the back, and Coast is going to go outside the room. So you guys are going to do an assessment on Meredith. The doc's going to watch over you guys, and then you're going to step off to the side. Once you do that, let somebody else work with the doctor, and then you guys go consult with Coast. Give him a rundown, just like you're requesting a helicopter. He's done this for a number of years in EMRC, so he's pretty spot on. And get yourselves in front of the doctor. Let her give us some feedback on how we're doing and what we're doing. And then if you guys want to practice stuff with the spine board, I brought a spine board up here. So we'll leave this mannequin up here for you guys to do other trauma assessments. So I'll stay up here with one group. Doc will be in the back with another group. And then you guys can practice consults. Questions, comments? Okay. Let's break. Let's do this for about 15, 20 minutes, half hour, as long as you guys want, and then we'll call it a night.